Good to go.
Hello everyone, welcome to week 8. Yeah, bit of an odd order here, but should be all right. All right, let's get into it. So I'm running you through thoracic cage and spaces, and that block isn't going away. So just as a brief note, if you want to look at some pathologies relating to the thorax, I didn't think they were super relevant to what you'd had in the lecture today, but and also I just didn't have time to run through them all, but they're in PSPlatypus slides from last year, and I've provided you the link here. All right, let's get into it. So the thoracic cage versus the wall versus the cavity. So we're talking about the chest generally. We're talking about the thorax. So the thoracic cage, when we're talking about that, we're really referring just to the cage created by the ribs. So you can see the ribs going down here, 1 to 12. When we're talking about the thoracic wall, however, we're talking about like most of the structures that create the enveloping of the thoracic cavity. So that's including the ribs, the vertebra, which is the spinal column back there, the sternum, which is this bone up the front here, and the intercostal muscles. So inter meaning between, costal referring to the ribs. So the muscles that run between the ribs that enable the expansion and contraction of the thorax. And this thoracic wall, it has multiple functions. So obviously we've got some important structures in our thorax, the lungs, the heart, particularly also the thymus. And so we want to protect them from injury. And this is a very effective way of doing that evolutionarily. And then also, considering the fact that the lungs are inside there, we need to be facilitating respiration, so that's breathing. So obviously it provides a space for the lungs to exist, and it also coordinates the movements, so of breathing in and that expansion of the chest, and breathing out and that constriction or contraction of the chest, or the thorax. And it also decreases friction, namely through the pleura, which we'll talk about in a little bit. And then we've got the thoracic cavity. So cavity meaning, space or opening. So the thoracic cavity is the space inside the thorax, and it has a superior and inferior aperture, which you can see here. So the aperture just meaning opening, more specifically. So you've got the superior aperture here between the ribs, the manubrium of the sternum, and the T1 vertebra. And then the inferior thoracic aperture down here, opening the thorax to the abdomen and below. All right, surface anatomy. So why is surface anatomy important? It's important because we can use them to orient ourselves, figure out where we are in the body. If someone's experiencing pain in a specific region, then that might give us a clue as to what structures are affected and potentially what the actual cause of the disease or the issue is, the presenting complaint. The key landmarks we want to be thinking about for the thorax are the clavicles. So that those are the bones up here that I think you have covered in upper limb. Then the suprasternal or jugular notch, which is this just here. It's that meeting of the clavicles and the manubrium, that sort of gap there. Then we've got the sternal angle, which if you travel down your sternum, it's the meeting between, and we'll talk about the sternum in a minute, the meeting between the manubrium of the sternum and the body of the sternum. The xiphisternal junction, or xiphisternal joint, which is the meeting between the sternal body and the xiphoid process. So that's the second and third parts of the sternum, the meeting there. The costal margin, which is the inferior margin of the sort of costal cartilage that you've got down here, running along here, the costal margin. And the xiphoid process, which is that third most inferior bone of the sternum. So those are the key landmarks of your thorax. And then also very important to consider are the lines. So generally they are defined by their relation to the the sternum, the clavicle especially, and the axilla, which is sort of the armpit region. So the most important of those, I'd argue, are particularly the midclavicular and mid-axillary lines, and also the parasternal. So parasternal just meaning besides the sternum. Midclavicular, so that's halfway along the length of the clavicle, and then just going vertically down, which is often about in orientation with I think the mammillary line, which is where the nipple is. But obviously that can vary phenotypically and with age. So generally we go mid-clavicular line, and that's very useful for getting our sort of y-axis on the body, on the anterior of the body. And then the mid-axillary line is midway along the axilla. So both very useful. We've also got anterior and posterior axillary lines, as you can see here. And we've also got sternal and anterior median lines, which are relatively self-explanatory. All right.
Wait, Carl, what are the purposes of
Yes.
these lines again? Like clinical.
So for instance,
clinical-wise.
clinically, I think when you get to cardio, there's, oh my goodness, I might get one of the other Platypus members to remind me specifically. But for instance, you might be looking at where you'd expect to hear, for instance, the apex beat, or where you'd listen for the different heart valves. And the way that you'll get your horizontal location is by going which intercostal space. So which space between ribs are you listening? So for instance, the fourth intercostal space, and then on the midclavicular line. So that way you're getting your sort of horizontal through the intercostal space and your vertical through the midclavicular, for instance, line. And that will tell you, for instance, where to listen, where to place the bell or the diaphragm of your stethoscope, or also potentially where to insert a needle, which is obviously quite relevant if you're trying to fix something like a pneumothorax where air has escaped from the lung into the rest of the thoracic cavity, which is compressing your ability to breathe. Yeah. Does that answer your question?
Yeah, it does. Was just interested.
Yeah, no worries. All right, so onto the sternum. We've got 3 bones in the sternum, and then we've also got 2 very important junctions or joints between them. So we've got the manubrium, which is the superior bone of the sternum, the body, which is the sort of long main one, and then the xiphoid process, which is this little one down here. They just connect to the rib cage. They're anterior. They obviously perform that protective function of the rest of the thoracic wall. But really what I want to talk about here is the sternal angle, and we'll get onto that in the next slide as well. But it's also known as the angle of Louis, and that's the articulation here between the manubrium and the body. It's at the second intercostal space, and the second rib, or really the second costal cartilage, connects here at this sternal angle. It's a major landmark. It's around the level of T4-5, so that intervertebral disc. All right. I'm not going to go into too much detail because I'm not sure that this was actually in your lecture, but it'll come up again and again. It's quite relevant because there are so many important structures at the sternal angle, so that level of T4-5, or maybe the lower border of T4, depending on what reference you check. So the mnemonic that people tend to use is rat plant, and that just has all of these structures here. Some of these you will not be, or quite a lot of these you won't be familiar with yet, because you haven't done the respiratory system yet, which is the lungs for breathing. So for instance, the trachea, maybe that's mostly it, actually. But you'll see a lot of vasculature, very important vasculature. For instance, the aorta coming off of the heart. The arch is here. You can see the heart is here. Got the arch of the aorta. You've got the second rib, which we mentioned earlier. The tracheal bifurcation. So that's where the trachea, which is your windpipe, separates into 2, getting ready to become the left and right main bronchi to supply the lungs. Don't worry, you haven't dealt with it yet. The pulmonary trunk, which is coming off of the heart and connecting to the lungs. the ligamentum arteriosum and the left recurrent laryngeal nerve, which are two separate structures, notably. The azygous vein, which is then draining into the superior vena cava. Other nerves, and the thoracic duct, which is involved in lymphatics. Lots of stuff in there. Worth learning, but not sure whether it's specifically been taught to you yet. So, okay, onto the ribs. Very exciting. Lots of stuff, lots of text. I think this page is probably more useful than like deeply analyzing the differences between typical and atypical ribs. But yeah, I'd say this is higher yield, but even then might be a little bit overkill. So we have 12 ribs, but they vary. They're not, as you can see, even in this picture, they're not all the exact same. They expand down at the bottom because we have more structures as we're going down into the abdomen, and also just for the shape of the body, that makes more sense. I don't have the deep evolutionary prerogatives there. Anyway, you can classify them as true versus false versus floating, or you can classify them as typical ribs and atypical ribs. So you can use either one. If we're using true versus floating, it's a little bit more straightforward. So true ribs, they articulate with using these costal cartilages, which is these sort of grayish blue things here. That's the cartilage. And you can see that they articulate, each one has its own costal cartilage to the sternum, right? So 1 through 7, arguably. In this diagram, it looks a little bit more like 1 through 6, but let's say 1 through 7. Then we've got false ribs 8 through 10, and they articulate through the costal arches. So you can see here, this entire structure here in the dotted red is a culmination of multiple costal cartilages connecting to the sternum through this like common junction here. So, yep, you've got those for false ribs. And then for floating ribs, they slope downwards, and they actually don't wrap all the way around and then meet through costal cartilages. So you can sort of see here, like I think the 11th rib and then the 12th rib down here, and it doesn't even get around all of the way. 12 protects the kidneys, and the angle, you can see they're relatively horizontal at the beginning, and then they sort of start having this downward slope because they are sort of all enveloping that thoracic cavity. Notably, each intercostal space is numbered as the same as the rib above it. So this intercostal space here, you can see between 1 and 2 would be the first intercostal space, which makes intuitive sense, I think, if you think about it for a second. But yeah, that's the first intercostal space, that's the second intercostal space, etc. You can also categorize ribs as typical versus atypical, and that's to do with their articulation with the thoracic vertebrae. And we'll see that when we look at a picture in a second. But typical ribs articulate with 2 thoracic vertebrae, whereas atypical ribs only articulate with 1 vertebra. Okay, so we can see this in this picture. I'll just jump to this. There's a lot of discussion here. I've copied it verbatim from PSPlatypus, and I encourage you to go through it in your own time. It's relatively understandable when you read through it. But yeah, so if we look at the typical versus atypical ribs, you can see that here we've got a superior and an inferior articular facet. So what we've got here, this is the back, this is the front, the costal cartilage that is connecting the rib to the sternum, remember? And then at the back here, we can see that it connects to vertebrae, but we've got an articular facet up here at the top of the head on the superior aspect, and that's connecting to one vertebral body, or one vertebra. I'm not sure that it's exactly the vertebral body. And then we've got another vertebra connecting here. So you can see that, and then we'd have an intervertebral disc here. So there's connection to 2 vertebrae, whereas an atypical rib would only be connecting to 1 vertebrae. This is rib 1, for instance, and then this is rib 12. So you can see how much ribs vary at this very superior rib, which you can't actually palpate because it's blocked by the clavicle. It's got this very sort of flat structure, and then, but it still comes all of the way around. Whereas on rib 12, you can see it's not coming all of the way around, and it's much smaller. All right. Yep. So you can see the articular facets here, and for its connection to both the one superior and one inferior vertebral vertebra. Oh, sorry. Don't really like talking about ribs that much. All right. Pleura. So pleura is a simple squamous layer of epithelium. And the way to think about it, I think the way to get your head around it, it actually ends up being 2 layers, but it's one continuous sheet. It's referred to as mesothelium, and it surrounds the lungs. There's also the pleura becomes pericardium around the heart as well, which you can see in this diagram embryologically. But yeah, when we're looking at the pleura, we're really talking about the lungs, and that's why, and it's named as such only when we're talking about the lungs. And it decreases friction when breathing. So it's basically like a really thin, like it's 1 cell layer thick, and then it's wrapped around and then comes around again. So it forms 2 layers. Between the 2 layers, we've got I think, oh my goodness, I'm blanking on the fluid. Parietal fluid? I'm not too sure. I'm sorry, I'll get back to this. But basically there's fluid, a very small amount of fluid that's connecting the 2. And that basically enables them to. Oh, sorry, I just got muted for a second. Odd, tech difficulties. Fun. Okay, well, basically it decreases friction when you're breathing, and it allows coordination between the thoracic cage movements and the lungs. So it is it coats the lungs, right? It surrounds the lungs, it envelops them. And it thus is the connection between the exterior thoracic wall, so that's the intercostal muscles, and then the ribs, and the lungs, which are further inside. And we actually have two layers of pleura. So we have that visceral pleura, which is the layer most internal, so most deep, and that's directly touching the lungs, whereas the parietal pleura is the layer that is further outside. And then between the parietal and visceral pleura is that pleural fluid that is facilitating the movement. I'll talk more about pleura at another time. I'm sorry, I'm blanking a little bit. Oh. Okay, we've got the diaphragm. That's the primary muscle of inspiration and really the main muscle of breathing. On inspiration, it's active. You're contracting your diaphragm when you breathe in, and that increases the thoracic cavity, the volume of the thoracic cavity. And then when you breathe out, you're passively allowing air to exit back out. But anyway, that's too much recipe. So it's the muscle that's down here. You can see this is an inferior view. So we're looking up at the diaphragm from sort of the abdomen where all of your guts are. And we're looking at it here and we can see the different hiatuses. So those are holes that enable communication of certain things between the diaphragm and the thorax, the diaphragm, and then the abdomen below. But really one of the key things that you'll have heard is this mnemonic C3, C4, C5 keeps the diaphragm alive. And that's referring to the innervation of the diaphragm by the phrenic nerve. So the reason that you might be going, well, why are they cervical nerve roots that are innervating the diaphragm? It's because the neck is the embryological origin of the diaphragm. So the lungs, all of these things are developing up in the neck, as is the diaphragm. And then as the lungs and the intrathoracic, the organs that are inside the thorax get bigger, they expand, and that expands the thorax down and pushes the diaphragm down with it. And so that diaphragm coming down pulls the nerves that it's innervated by from the neck down. So that results in the phrenic nerve traveling down here and innervating the diaphragm. We can also see here, we'll also sometimes hear phrenic. Phrenic is also referring to the diaphragm. So we've got the right and the left costophrenic angles here, which is this angle here inside the thorax. And you might be able to imagine if we had fluid that was collecting inside the thorax, you can see that sort of, it makes sense. These are sort of the gutters of the thorax. This is where fluid would collect. And you can see that, for instance, in a pleural effusion, where the, I think if there's puncturing or there's fluid collecting in the thorax from the pleura, and it collects down here, you'll see blunting. So if you looked on I think an X-ray, you'd be able to see that this wouldn't have these nice sharp angles down when you're imaging, when you're doing a chest X-ray, you'd actually see a flatter angle. And so you'd see blunting of the costophrenic angles. I've just illustrated the right costophrenic angle here, but there's also a left costophrenic angle, and there's nothing special about the right one. The right crus, so the diaphragm is made up of different crus, so different sort of wings. The right crus of the diaphragm is higher than the left, and that's because the liver is here and it's quite big, so it pushes up a bit. And so you actually have a slightly uneven diaphragm from one side to the other. Okay, we're almost done. Thank goodness. Intercostal muscles. So they're also muscles of respiration, but they sort of more so enable the expansion of the chest. They help with breathing, but really the diaphragm is that primary mover. Intercostal, once again, meaning between the ribs, muscles. So we've got lots. We've got about 5 layers, but really we're most concerned with these 3. They are innervated by the corresponding intercostal nerves. So these nerves, these intercostal nerves and veins and arteries run in the subcostal groove, which we'll talk about on the next slide. But basically they run around in sort of these layered rings, right, in between all of the ribs. And so it makes sense, for instance, that this nerve would be innervating these intercostal muscles in this intercostal space. In terms of the layers of muscles, so we've got from the outermost to the innermost, we're looking at the external intercostal muscle, and I've written here just some mnemonics for the remembering how the fibers are oriented, and that helps with thinking about their movements. But yeah, you've got the external intercostal muscle here. That's the outermost of the intercostal muscles. And that sort of has a hand in pocket. So if you put your hands in your pockets, in your front pockets, you'd be able to see there's this sort of downwards, forward sloping fiber, which you can see here as well. Internal intercostal, hands on chin. So it's doing that sort of opposite direction. Then innermost intercostal, and between those two, you've got the neurovascular bundle between internal and innermost. And innermost sort of has vertical fibers. Then you've got subcostal, which is here, and that's sort of, and then you've also got transverse thoracic, which is here. So those are slightly less important. All right, almost done. Sorry for a weird anatomy run through. So veins, artery, nerves, that's what this mnemonic is. Here we're going from caudal, cephalic to caudal, top to bottom. So vein, artery, nerve, and that's the order of these vessels in the neurovascular bundle, the main ones, not the collateral branches. So they run between the innermost and internal intercostal muscles. As I noted earlier, you can see between that. So you've got the first external, second internal, and then you've got the innermost, which is that third layer. And between the second and third layers, you've got the neurovascular bundle. You've also got smaller collateral branches that run lower, and they run the main ones under this subcostal groove. So you can see that the rib actually has a sort of outpouching, a little protective space here that is somewhat protecting this neurovasculature. But because the nerve is sitting out, it's still sort of exposed, right? And so in terms of clinical relevance, if you're sending a needle in there, for instance, to drain fluid, predominantly I think would be, or to enable air to escape if it's collected outside of the lung, but still in the chest, which we'd call a pneumothorax, which is very dangerous, then you don't want to be causing unnecessary damage. And so that's why we need to consider where this nerve is and insert our needle accordingly. So we want to insert the needle just between the ribs, sort of in the middle, or actually just above the lower rib of the two that are creating this intercostal space. And that way we'll actually sacrifice the collateral branch, but they're less important than the main intercostal nerve. So it's better to sort of risk that than risk damaging that intercostal nerve. And that's about it. Thank you.
All right, thanks, Kyle. Let me get started in just a moment. Also, the name of the fluid between the mesothelial layers in general is called serous fluid, and within lung pleura, it's called pleural fluid. But yeah, all that stuff is in chat for this. Who are interested? Okay, cool. So I'll be talking about centrally acting analgesics. So this is really about opioids and a bit more info that we'll be adding on to what I talked about previously in the physiology lectures on pain. So when we think about opioids, what they really are actually just opioid receptor agonists. And you might remember endogenous opioids that we talked about briefly in the descending pathway of pain. Make sure to have a quick look at that stuff if you don't remember. But opioids essentially, they mimic the endogenous peptides and target the opioid receptors in the spinal cord and in the brain. Again, endogenous means it's produced by the body, so that's small peptides produced by neurons. And exogenous is stuff that's externally synthesized, like the opioid drugs that we typically use. When it comes to opioid receptors, there's a bunch of different types. We've got mu receptors, delta, and kappa receptors. The thing that we're most concerned about or concerned with is the mu receptors, because they produce most of the analgesic effects and also most of the adverse effects, which we'll be talking about in a second. The delta and kappa only really have some analgesic effects. So again, a bit of revision on the descending pathway. So this is really when afferent pain signals is carried through to the thalamus, which is then stimulates the periaqueductal gray matter in the brainstem region to provide descending inhibition, which sends nerve impulses to interneurons within the dorsal horn. And these little interneurons are essentially like little factories that produce enkephalins, and these enkephalins bind to opioid receptors and stop the transmission, hence inhibiting pain. So we're just going to talk about a bunch of different types of opioids. So you might be aware of like these names might be quite familiar. So for example, morphine. So that's going to be the kind of the thing that we're going to talk about relative to in terms of the mu receptor affinity. So this is kind of like the potency of the opioid. So for morphine, which we assign as 1, we generally use that when there's severe pain. For codeine is it's a morphine prodrug, so it's before it's like the drug that needs to be sort of acted on by the liver in order to produce morphine. It has a potency of like 1/5 of morphine, but it's better absorbed and potentially less addictive. So it has its own clinical uses. And you have oxycodone, which is similar to morphine, just a little bit more potent, yes. And then you have fentanyl, which is extremely potent and is used in breakthrough pain. So breakthrough pain is pain in chronic conditions where patients are typically already on a pain management plan, but these chronic conditions, they flare up like cancer, arthritis, and they cause immense pain. And then that's really when you need to use fentanyl. You got heroin, which is a bit more than morphine or double morphine. And we have 2 more, which we're going to talk about in more depth. So loperamide and naloxone. So loperamide, we didn't assign any affinity here because it acts a little bit differently to these different opioids. This is mainly to treat diarrhea. Now, one side effect of opioids, and this is essentially all of them, is that they cause constipation. And the way in which they cause constipation is by inhibiting enteric, or enteric meaning gut, motility. How do they do that? They do that because by inhibiting cholinergic nerves that are required for passing of stool, by increasing tone, we stop the movement of stuff, and that causes constipation. Now, this is actually pretty useful in a case where someone has diarrhea, since we slow down movement of bowels. So, for example, in loperamide, it's poorly absorbed into the bloodstream. So, like, it doesn't have that much of an analgesic effect, and only really acts at the GIT. So, this allows us to specifically target the gut and have an anti-diarrheal effect. Naloxone is the other one. So that's an opioid antagonist. Now, we talked about opioids and how they bind to these opioid receptors to have their effect. Now we're talking about naloxone, which is the opposite of it. So it binds to these receptors and prevents opioid from binding to it. So it's typically used to temporarily, so very important that it's temporary, treat opioid overdoses. So, for example, let's think about the effects of opioids and kind of what naloxone would do to them, because it would kind of do the opposite, right? Since it's meant to be an antagonist. For example, analgesia, that's the main clinical use of opioids, and naloxone might cause someone to experience more pain, since the descending inhibition is going to be stopped, because endogenous opioids like enkephalins will no longer really work. Other effects of opioids include euphoria, dysphoria, sedation, constipation, like we talked about, nausea and vomiting. So this is
Wait,
pretty...
Deepak, could you please repeat what you said about the descending pathways? I'm so sorry to interrupt you.
Okay, no worries. So
No, just now about analgesia, not...
all right, okay. So since endogenous opioids like enkephalins are used in the descending pathway, by using naloxone, which is an antagonist to the opioid receptors, we essentially cause an increased sensation of pain, because normally our body produces stuff that suppresses pain, right?
Yeah.
That kind of makes sense.
Yeah, I get it now.
Yeah. All right, cool. So there are a bunch of different effects of opioids. Nausea and vomiting is something that's pretty clinically relevant, and it occurs in a lot of cases from morphine, which is what we use clinically. It correlates with potency as well, and it does this by stimulating the chemoreceptor trigger zone in our brain. Don't really worry too much about that though. There's some drug-specific side effects, like the release of histamine, for example, in morphine and heroin, like itching, urticaria, which is like hives at the injection site, and other mast cell kind of effects like bronchoconstriction and hypotension. The main thing that we're really trying to prevent by using naloxone is cardiovascular or respiratory depression, which is when our body essentially, since opioids inhibit the like just an action potential, it kind of makes sense that if we have too much of an opioid in an overdose, it would cause us to stop nerve conduction in other vital function like cardiovascular and respiratory function. And that inhibition is very dangerous to us. So this is what we look for when we want to use naloxone. There's one more drug called tramadol. So in the dorsal horn, since we talked about in the descending pathway, just remembering really quickly that interneurons release enkephalins, tramadol increases noradrenaline and serotonin, or 5-HT, in the dorsal horn. Much like enkephalin action, so these two neurotransmitters actually inhibit nociceptive transmission at the dorsal horn, kind of like a similar effect. And this is pretty similar to some antidepressants, since they raise noradrenaline and 5-HT levels in the brain and the spinal cord. And the adverse effects are more linked to increase in serotonin, like nausea and vomiting. And that's that for my part.
Yep, I think I'm up next now for anatomy of the back. Thanks, Deepak. I'll just share my screen. All right, let me know if everyone can see that. And if so, I'll just get started. Okay. All right, so again, as with last week, my last anatomy lecture, I just want to emphasize that I know a lot of you are finding some of the anatomy confusing, and just to reassure you, we all found it really, really confusing last year, learning it all online. And the thing is that with anatomy, it's sort of a piecemeal process. So what you'll find is that everything starts to make more sense as you move through different body systems. It's kind of like one of the world's most complicated puzzles, right? Each bit will get easier as you start getting more and more pieces, and you can really start connecting the dots and building a better image of what everything looks like in 3D. So what I advise is that really try and focus on learning as much as you can throughout the lectures. And then as you go along, you'll find that things just click into place. And to help you with that in this lecture, I've sort of put these little puzzle piece icons throughout wherever I felt that a certain topic is not going to make sense just yet, and it probably will make sense a bit later. So just keep an eye out for that, and don't be confused at all. If it doesn't make sense now, it will make sense later on. All right, let's start off with the actual osteology, also the bones of the spinal column. So the spinal column, we are all sort of have seen it quite well, in models and in diagrams of human skeletons, but it's basically a stack of vertebral bones. That's why it's called the vertebral column, because it's a stack of these bones. And this column's main purpose is to house the spinal cord, which we'll see a little bit later on as well. But we generally break up the spinal column into different segments, being the cervical segment, thoracic, lumbar, sacral, and coccygeal. And they each have different numbers of vertebrae composed inside them. So what you can see here is a little mnemonic that a lot of people use to remember the order of these, because the first time you see it, it won't make sense entirely. The way you can think about it without a mnemonic as well is that cervical refers to your neck, which is kind of confusing because you might think cervix, right? But it's actually referring to the neck here. So cervical is referring to the neck, so it's the highest one. Then you've got thoracic, which is the thorax, or like your rib cage, which we just covered previously. And then lumbar is to do with your lower back and around the abdomen, which you'll learn about next year. So don't worry about the abdomen too much just yet. Sacrum and coccyx you would have already covered with lower limb. It's that bit of bone that connects the spine to your pelvis, and therefore your upper body to your lower limbs. And you've got this nice little mnemonic here that can help you remember that order if you're struggling with it at this stage. But you've also got a second mnemonic here for the number of vertebrae in each segment, right? So it's important to remember that there's 7 vertebrae for cervical, 12 for thoracic, 5 for lumbar, and then for sacrum and coccyx, they're actually not individual vertebrae. They're fused vertebrae. So you don't have to remember them as separate vertebrae. Just remember that they're one fused bone, and therefore we refer to them as the sacrum or the coccyx rather than sacral vertebrae. And also the second thing here, which you'll probably go over in your lectures as well, but I've put in here just for completion, is the curvature of the spine, which we'll cover later on for clinical anatomy as well. But in terms of curvature, there's two types of curvature you can find in your spine: lordosis and kyphosis. Lordosis means it's going to curve anteriorly, so curve forwards. Kyphosis means it's going to curve posteriorly or curve backwards. The way that I remembered it is, and I'll show it later on as well, is that with lordosis, think of a fat lord, right? Like a lord, and that belly is coming out. So that's your lordosis, anterior curvature. And then kyphosis is the opposite of that. So you just want to remember that in the cervical region, you've got a lordosis, and then you've got a kyphosis, and then a lordosis and kyphosis going down the spinal cord, the spinal column. The last thing you also want to remember is whether that curvature is secondary or primary. So secondary basically means that, or primary, first of all, means that it was present during fetal development. So it's inside, it's developing and it's developed when you're in the womb, right? Whereas secondary refers to it forming after birth. So once you're born, it takes a little while after birth for that actually to develop. And so it's not going to be present in a newborn, or it's developing in a newborn at least. Okay, so that was an overview of the bones, but now we're going to talk more about the individual structures of the vertebrae. So we talked about, if you go back a little bit here, we talked about the vertebral column, but now we're going to talk about the individual coins in that stack, or the vertebrae. So if I go forward, you can see that with the vertebrae, we first of all have two very basic structures: the vertebral body, which is going to bear all the weight of the structures that are connected to it, mainly the head, and the vertebral arch, which is sort of that bit which comes out the back, and you can sometimes palpate on your back as well. You also have your vertebral foramen, which is a little gap between the vertebral body and arch, which is actually going to contain that spinal cord. So that's an important thing to look out for in your specimens and imaging as well. Probably not in imaging, but more so in specimens. And that's going to contain your spinal cord, so the nerve that's going to run through it. And the next thing you have to also keep in mind is that with the vertebral arch, you actually have to know a little bit more about it. So know about the individual parts of the vertebral arch. So there's the pedicles, which are these green bits here that come directly off the vertebral body. Then you've got the lamina, which is again another bit which comes around to form that complete arch. But then from that arch, you also have some processes coming off that allow it to form joints with adjacent structures. So the transverse process here is shown right there. And in some cases, it's actually used to articulate with the ribs, for example, but there's actually specific things we'll talk about for that later on. You've also got probably the most important ones here, the superior and inferior articular processes, which is basically the hands and feet that allow it to connect to the vertebrae above and below. So you can have a look at the diagram here, which shows just that. So you've got the inferior process of one vertebrae and the superior of the one below it, and then they articulate together so that those two vertebrae are connected and not just separate things. And I like thinking of the vertebrae as sort of a person stuck inside a box with his hands up like that and his feet down, and that the hands that are up there are the superior articular processes, and the feet below are the inferior articular processes, and they can articulate with the vertebrae above and below. All right, so next up we have this slide over here, which is showing a very important point, that even though in the previous slide we learned about the vertebrae and its anatomy, that's just a very general picture overview, right? In reality, the individual vertebrae have separate structures because they're located at separate places throughout the body, and therefore have different functions, which we're going to be covering in the next few slides. So first up, you have your cervical vertebrae. And with the cervical vertebrae, again, it's located in your neck region or the cervical region. And you're going to be talking about 7 vertebrae there, because if you remember the mnemonic, it was, I think it was, you have cereals at 7, which is that C1 to C7, right? And with this, with the vertebrae here, the C1 and C2 vertebrae are very, very special because they are going to be the connection between your spine and your head or the skull, right? So they actually have a very special structure, which is shown here, and you can have a look at it in more detail online as well with labeled diagrams. But they've got this structure which allows them to articulate with the base of the skull and the rest of the vertebral column. So I invite you to have a look at that and have a look at the detailed diagrams online as well, which actually label the individual parts. I haven't done that here because it's not entirely high yield, although you'd probably go over it anyways in imaging and specimens. But the next bit is the rest of the vertebrae, which are a bit more uniform compared to C1 and C2. Oh, and by the way, the diagram over here is showing, I think it's the Greek Titan Atlas, which is why it's called Atlas, because I believe the myth goes that he held the world on his shoulders. And similarly, this Atlas vertebrae is holding the entire skull. So that's why it's sort of named that. And the C3 and C7 vertebrae are also shown here. They're also shown here in a line. And they've got a number of important characteristics that make them separate from the other vertebrae in other regions. So you've got the fact that the spinous process of the part coming out the back. So if we go back a slide, actually, the spinous process was the part which comes out over here, right? That bit, the posterior process, is actually bifid. So it splits into two or bifurcates for all of the cervical vertebrae, except for C1, because again, it's the special Atlas piece. And for C7, which is actually also special because it's not bifurcating, it's forming this very long process that you can actually palpate at the back of your neck. And it's one of the first vertebrae you can actually palpate when you go down from your head to your neck, which is why it's used as a very good landmark. And it's called the vertebrae prominence because it's very prominent in that region of the neck. The next thing is that with the foramens, or the part which is actually going to house the spinal cord, it's triangular in the case of the cervical vertebrae. So if you look over here, you can see the foramen there. The foramen is actually triangular. And the last thing is that they also contain transverse foramina. So these holes on either side of the vertebral body, which allow it to convey the vertebral arteries and the vertebral veins as well, which we'll see later on. And next up, we have the thoracic vertebrae. So they're located in the thoracic region. So below the cervical, and connecting to the ribs. So it's going to be very important. And we already covered a little bit about the rib cage and the thorax with Kyle previously. So it's going to be a very good connection to that from here. So you can see how these vertebrae actually connect to the ribs and are able to articulate with them, which is very, very useful because we want to be able to do that specifically in the thorax region, but not anywhere else because the ribs are only in the thorax region. With the characteristics of the thoracic vertebrae, the spinous process is oblique and it's also quite long, right? So you can see here that the spinous process is oblique, meaning that it actually goes downwards. So it starts off high and then it goes into an inferior, so an inferior and posterior direction. So it goes downwards like that, right? And that's, and again, another defining feature of that. The vertebral foramen is also circular, and there's what's called 4 demifacets. So there's sort of these parts on the sides that allow it to articulate with the ribs. So there's the 4 demifacets and the 2 costal facets, which you can also see there on the diagram if you zoom in a bit. All right, so the next 2 are the lumbar and the sacral and coccygeal. So we're going to be covering the lumbar first. So the lumbar vertebrae, again, have some important features. The main thing being the spinous process here is actually short and oblique. So before, the one on the thoracic region was very long and oblique. Over here, it's going to be short and oblique, but the same direction of inferior posterior angling. The vertebral foramen over here is triangular, all right? And that's a distinction between that and the thoracic one, which is circular. And the last thing is that it has no transverse foramen. So it's not going to have any of those transverse foramen or those holes because the vertebral arteries have already come off and left. All right, and then the final one is the sacrum and the coccyx, which is again, they're not actually individual vertebrae, they're just fused vertebrae. So the sacrum is 5 fused vertebrae, and the coccyx is also this tailbone piece at the bottom, which is going to articulate with the sacrum inferiorly. And again, you've already covered that a little bit with lower limb, with the parts of the pelvis. It basically is that bridge between your pelvis and your spine. So it's going to connect your upper body to your lower limbs. And then the next thing we have here is the ligaments. The ligaments are arguably a bit hard to understand when you first look at them. But there's a couple of diagrams here which are trying to show that relationship between the ligaments in a 3-dimensional view. And I put the little picture of a vertebrae here again, because a lot of the names of these ligaments are actually very, very well named, except for one over here, which I'll cover, called flavum. This ligament flavum. It's called flavum because that apparently means yellow in Latin, which I think is one of the worst things to name a structure, just calling it flavum because it's yellow. So often you find anatomy that some things are just named really horribly, but for that case, we're just going to memorize what they mean. So the first ligament you're going to be talking about, so go from posterior to anterior, so starting on the back and then working your way forward. The very first ligament is a supraspinous ligament. So the confusing part here is you might think supra means superior, but in this case, supra actually means superficial too. So it's talking about this ligament being superficial to the spinous processes, so lying on top of them and connecting them all together. Interspinal is also going to be between the spinous processes, and you can also see it over here on the diagram. It's connecting the individual spinous processes together. And flavum again means yellow, but it's actually, its location is that it's between the laminae. So if you look over here, the laminae was the purple bits at the end of the vertebral arch. So it connects those together. And then you also have the last two, which is the anterior and posterior longitudinal. So the posterior one's over here, but behind the vertebral body, and the anterior one's in front of the vertebral body. And yeah, they run vertically in those areas. I'd say probably it's important to remember the order of those ligaments, just so you can have an idea of where they lie orientation-wise. So the most posterior one, supraspinous, then interspinal, then flavum, then the posterior longitudinal, and then the anterior longitudinal. And I know that this diagram over here is kind of confusing because it doesn't look very much like a vertebrae, but what you have over here is the vertebral body, then this is the vertebral arch, and this is the spine, as you can see over here, that bit over there coming off, which you can only see part of. I hope that sort of helps you orientate with the image, but if not, feel free to let me know in the chat and I can explain that again. All right, so the next bit over here is something you'll be covering again in the lectures and imaging and specimens. It's about facet joint orientation, an idea that I found really confusing when I first heard about it, but I think that if you sort of just try and visualize it, it makes a lot more sense. So the idea is that the movements at the different areas of a spinal column depend upon the joints formed by the vertebrae, and the joints between adjacent vertebrae by the superior and inferior articular processes, they're called facet joints. Now, you'll see diagrams like this online, which are showing the sort of orientation of those facet joints. So you've got the cervical, thoracic, and lumbar orientations, and they're kind of confusing to understand. So I think that if you just grab a friend and put your hands into those orientations, it actually makes a lot more sense. So here's me doing the same thing. And what you can see on the right here is that the cervical facet joint orientation is between coronal, so coronal being like this, the coronal plane, and transverse being like that. So it's between those two. So about 45 degrees between those two. And what that means is if I have two hands like that, you can do the sliding stuff, you can do the lateral flexion and sort of lateral flexion and extension and rotation. That all sort of works with that setup, right? Coronal here is the exact same idea. It's where you're having that coronal plane and the facet joints are in that coronal plane, which means you can do everything you want. So you can do the flexion, extension, lateral flexion, extension, and rotation. The key idea here, probably the most important one of all of this stuff, is the last one, which is the lumbar vertebrae. Their facet joints are in the sagittal plane, right? So, or not sagittal, but almost sagittal plane. So sagittal being like this, right? So if you imagine the vertebrae articular processes is lining up like this, and if you have two of them being adjacent, as one tries to rotate, it's getting sort of confined by the other one, which is kind of hard for me to show with just my two hands, but that diagram over there shows that in a bit more, I guess, clarity. And you can see that if that person who's on the inside tries to move and rotate, they can't because the other vertebrae is limiting that rotation, which is why if you look at the diagram here, you can see rotation of the head and neck, rotation of the upper trunk, but nothing for the lower trunk because lower trunk rotation is pretty much non-existent because of the orientation of those vertebrae. I hope that makes sense. And again, you'll be covering it again anyways with your lectures and imaging and specimens. Yeah, so the main idea here is there's no rotation with that lumbar vertebrae. The next thing to talk about is the intervertebral discs. So you have these vertebrae, but again, they're weight-bearing structures. So you want to have a little bit of cushioning or shock absorption between them because you're not going to be just bearing weight, but also going to be jumping around and moving around, which means they're going to be in constant motion and constant pressure from below, from the legs, and from above, from your head pushing down onto it with gravity. So you want to have a little bit of cushioning between these vertebrae, and that's given by a shock absorbing disc called the intervertebral discs, which are located between the vertebral bodies. So the arches actually aren't involved here at all. It's just the vertebral bodies. And we care about these because they are going to be important later on for disc herniation, which we'll talk about in a second. Well, at the end of the slides with clinical applications. But anatomy-wise, you have to know the structure of these discs. On the inside, you have a nucleus, which is that inner bit, which is quite pulpy and gel-like. So we call it the nucleus pulposus. It's that gel-like shock absorber, which is actually going to be responsible for absorbing a lot of the impact from holding stuff and jumping around. And then you have your annulus fibrosus. So annulus basically means ring. So it's a ring formed around, and fibrosis because it's quite stiff and fibrous. And it's these stiff rings or laminae, which is another name for those rings, that can actually withstand compressive forces. And I like to think of it as a container that actually wraps around the nucleus and keeps it in. So it prevents it from coming out and sort of leaving the vertebral bodies, right? All right, so next up, we have the muscles. So the muscles is quite a few of them. So I'm actually not going to cover them in too much detail because, first of all, the extrinsic muscles, you've already covered quite well in upper limb. And the intrinsic ones, again, there's a lot of them, but they're not very high yield, at least to my knowledge. And someone else probably can talk to that in the chat if they have their opinion about that. But I don't think they're extremely high yield. But I'll just include them here anyways. And if you do want to know more about them, in the notes for these slides, I've actually put in links to both the PSPapa and PSPingu slides for muscles, where they literally list every single thing. So they list the muscle, the insertions, origins, the innervation, the blood supply. Not all of it is going to be important. And I've just put what I think is high yield, but just have a look at them if you feel like you want to make more complete notes. And yeah, so with your muscles at the back, you have two broad categories: extrinsic. So extrinsic meaning that the origin and or insertion is not on the vertebral column. So that's sort of your upper limb muscles, which we discovered sort of in, was it week 1 anatomy, where we talked about the upper limb and the trapezius muscles, deltoids, and things like that. A lot of those muscles are going to connect your vertebrae to your shoulder girdle. And so those muscles we've already covered. I'm not going to go into them, but I've got diagrams of them here anyways. The only new muscles with the extrinsic ones are the serratus posterior muscle, which we'll talk about in a second. And then you have your intrinsic muscle group, which is the origin, which is where the origin and insertion, they both lie on the vertebral column. And so only produces movements of the vertebral column specifically, not of the shoulder girdle or anything like that. All right, so here are your muscles. So there's your muscles you already know about from upper limb. These are the extrinsic back muscles, which are superficial and higher up: trapezius, levator scapulae, rhomboids, latissimus dorsi. Already know about them. Won't go into them in too much detail, but you've got the muscle and innervation there. And again, it might not have been memorized by now, like sunk in by now, but you will sort of get used to it as you repeat it over time. And then the last two new ones are serratus posterior superior and serratus posterior inferior. So they're called serratus because they look like a serrated blade, I guess, because they've got those teeth on them, and they're posterior, so at the back. And one is superior, higher up, one is inferior, so quite easy to remember where they are and what they do. And the innervations are also there. They're innervated by the ventral rami. So if you have a look at the spinal cord, the ventral rami, the ventral ramus, actually innervates these muscles. One thing I wanted to add here as well, let's have a look. Nope, I think that's basically the majority of it. So superficial over here, intermediate over here, or deep over here. And on the next slide, we have the intrinsic back muscles, which are, again, there's 3 broad categories here: superficial, intermediate, and deep. Superficial wise, you have 2 muscles, splenius capitis and splenius cervicis. Now, the good thing about these muscles are that they're actually named quite well, kind of. So the splenius part is, I think, a bit of a bad name to give to a muscle, because splenius apparently means bandage in Latin. So apparently it looks like a bandage, which I don't know if I can really see that, but we'll go with it. And then capitis refers to the fact that it connects to the head. So think per capita, right? Per head. The capitis part means that it connects the head or the skull to your vertebral column. So you can just think of it and remember it that way. Splenius cervicis, it's kind of hard to appreciate in the image up here. If you look down here, you can actually see it's going down to the vertebral column again. So it's just connecting the cervical vertebral column to itself. So that's why it's called cervicis. And I've got notes on that below as well in the notes section. So you can have a look at that if you're a bit confused about that. And then you finally have your erector spinae muscles. So the intermediate layer of intrinsic back muscles, iliocostalis, longissimus, spinalis. Again, they're all named quite logically, except for probably longissimus. It's called that because it's long, which is very creative. And then iliocostalis is named very well because it connects your iliac part of your pelvis to your costal part or the ribs, right? And you've also got the innervation there, which is not too flashy or important to remember. And about the innervation, they're basically innervated by the dorsal rami of the adjacent spinal vertebrae sections. Okay, the final layer, which is going to be the last one we're going to be covering for muscles of the back, is the deep intrinsic back muscles, of which I think the diagram here should be different. I'll fix that up later on, but there's basically these muscles labeled over here. The diagram is not correct for that one, but I'll sort of fix that up. But the main thing you have to remember is that they're all innervated by the spinal nerves of dorsal rami, except for one of them, which is intertransversi, which is special because, and I think in specimens you might actually get asked this in one of your worksheets, but it's the only intrinsic back muscle which is actually innervated by a ventral rami instead of a dorsal rami. So just keep that in mind. A little bit of a neat trivia thing. Clinically important, probably not, but they like asking you about it anyways. All right, nerves of the spinal cord. So let's talk about the actual spinal cord and the nerves that lie inside of it. With that, right, so here on this diagram, you can see what I was saying before. The spinal cord is within the vertebral column. It's lying between the body and the arch in this pocket called the vertebral foramen, right? And that's the spinal cord here. You would have seen that so many times in your physiology lectures, and you would have covered it to death in pharmacology, physiology. So I'm not going to talk about the spinal cord structure in itself with the horns and the different parts of it. I'll talk more about the general anatomy. And the first thing you want to learn about is that the spinal cord, again, is in the vertebral canal, but the most important part to cover is that where do the rootlets or the rami actually emerge from? And they emerge between the vertebrae, between the arches. And so that place where they emerge from is because it's sort of a hole or a foramen. We call it, again, a foramen. But because it's between the vertebrae, we call it intervertebral foramen. So that's how you can remember where these roots and rami emerge from. So they're quite well protected until they emerge out and then travel to wherever they want to go. And you can see again in both these views here. And now here's a bit of more of a complicated diagram, which is very important to wrap your head around, extremely high yield. And I'll talk about a few of the important parts of the diagram. So the first thing is learning about how are these spinal nerves actually labeled, right? Because you've got your vertebrae, which are the bony bits, and then you've got your spinal cord, which is the nervy bit, right? So you want to learn about how those are named or what levels they're given. So the easiest part to remember is that when you're starting off at the top in the cervical region, each of the roots emerge below the corresponding vertebrae. So the C1 spinal nerve root will emerge under the C1 vertebral bone. Easy enough to remember. The annoying part, which I don't really understand why this is the case, but the annoying part is that the C8 nerve is apparently skipped. So there is no C8 nerve. So you just go from C7 to T1, but we do have a C8 bone though. So that's sort of a problem. So we skip over C8 nerve, we still have a C8 bone there. So what ends up happening is that instead of having C8 below the C8
Hey, J-Nil, the diagram that your laser pointer's right on, it says C8 spinal nerve exits below C7 vertebra.
Oh, right. Sorry, my bad. I think I mixed that up then. It should be that
C8 nerve is not skipped, right? Then
C8 nerve is there, sorry, and the C8 bone is missing.
Skipped, yeah.
Yeah, perfect. So thanks for reminding me that. I actually added that as well in the slides. But yeah, you're right. The C8 bone is skipped, but the C8 nerve is there. Therefore, what happens is that because you still have the C7 bone there, C8 is going to be below that rather than some other nerve there, right? So I'll actually edit that and fix that up. But the main thing you have to remember is that, yeah, it should actually be changed here as well then. The roots emerge above the corresponding vertebrae, above here. So C1 should be above C1. C1 nerve root should be above C1 vertebrae. And then below that, it's the opposite, where the nerves exit below the corresponding vertebrae. So I'll actually edit that. So the below should be above here and the above should be below here. And instead of the C8 nerve being skipped, it should be the C8 bone being skipped. So thanks for reminding me that as well. Really good observation there. Next up, we have termination. which is the part where we actually reach the end of the spinal cord, right? And that is called the conus medullaris. The spinal cord actually ends at the bottom at a section called the conus medullaris, which is shown over here, the termination of the spinal cord. It's about the L1, L2 level. The way that I sort of remembered it is that at L1, the spinal cord is done. And so L1, L2 is where the spinal cord is done, right? And however, what happens is that even though the spinal cord, that thick cord is actually done, the strands themselves actually still continue downwards. And they continue downwards, sort of like a tail-like structure, like it looks like a horse's tail. So we call it the cauda equina. And that's, again, that tail-like stuff, which is continuing downwards into the sacral region and well below, right? All right, what else is important there? So that's basically a termination of the spinal cord. And the last bit is enlargements. This is really, really easy to remember because you've already covered the brachial plexus and the lumbosacral plexus for your upper limb and lower limb. So where you need the most, I guess, nerve activity is in those regions because they require very complex motor movements. So in those regions, the spinal cord is actually enlarged and thickened. So that's why you have 2 points of enlargement, the cervical region for the brachial plexus and the lumbar region for the lumbosacral plexus. So that's just the 2 important things to keep in mind for the enlargements when you look at the anatomy of it. Next up, we have your meninges, right? So your meninges are these thin membranous envelopes that wrap around the brain and the spinal cord. We don't care about the brain just yet. You're going to be covering that next year. We're covering it right now. So you don't have to worry about it at all. You have to worry about the part that wraps around the spinal cord. So first of all, we'll start off from the very outside and work our way in. From the outside, you have the epidural space, which again, we will talk about later as well, but that actually contains your vertebral venous plexus, right? And below that is the dura mater, which is the tough and thick layer that surrounds everything. And by the way, if you're wondering why it's called dura mater, arachnoid mater, pia mater, again, the naming here isn't that great. Dura is good because dura means durable, thick. Arachnoid is called that because it's apparently looks spidery, like a spider's web for some reason, or it's just spiders around in some way, like structure-wise. And pia, not too sure what that means, but they all sort of have names which reflect the structure, but not so much where they're located. So the way you remember the locations is the mnemonic DAP. So D is for dura mater, then A is for arachnoid matter, and then P is for pia matter. So working your way from outside to inside. But in between those layers, you also have some spaces. So the outermost one is the epidural space, which contains your vertebral venous plexus. The space between the dura and the arachnoid matter is called the subdural space because subdural cavity, because it's below the dura mater. So subdural is a potential space. So it's not actually a space that contains anything, but it can become, I guess, filled with fluid and therefore become a space. So that's what's called a potential space there. The subarachnoid space, very well named, below the arachnoid layer. And that contains the cerebrospinal fluid. Extremely high yield to remember that. Remember that the subarachnoid space contains the CSF. That's going to be very important later on for clinical stuff as well. And then finally, the innermost thing you have is a spinal cord. So just have a look at that and get your head around all that stuff. And I've also made a couple of notes here for specimens because I remember they asked some very small trivia points here. Like how do you tell that, first of all, like a very important one to remember is how do you tell what's anterior and posterior of the spinal cord? And you might have noticed that with anterior, you've got this fissure here, right? And I think it's called the anterior median fissure. You can use that to tell that it's the anterior part, although it's kind of hard because you've also got the posterior median fissure, but it's actually sort of longer and continues in. And you can also use the fact that the rami sort of come out ventrally, sort of angled ventrally, so you can use that as well. And yeah, have a look there and see if you can figure out what anterior and posterior is. Just trying to look for some signs there of that. And the last thing as well on the left image, which is kind of low yield, but again, a trivia point, is that there is a nerve that exits from the spinal nerves, but rather than actually going out to some part of the body, it actually goes back onto the spine. So this nerve is called the recurrent meningeal nerve because rather than actually heading out from the spine, it actually wraps back around and goes into the spine to innervate the facet joints, the annulus fibrosus, the ligaments, and the periosteum of the spinal canal. And they're not muscles, so they're not going to do anything like contraction-wise, but they are bony structures that you want to innervate for pain sensation. And also with that, just keep in mind that the inner pulpy nucleus pulposus structure is actually not got pain innervation. So that's why It makes sense because you're constantly compressing it, so you wouldn't really want to have pain innervation there. Vasculature, I put the little puzzle piece here because, again, it's not going to make sense today, or for a while at least. A lot of it actually isn't that relevant for this year, but the most important part I've put, I think, is that these two bits over here, you probably could be asking about the anterior spinal artery and the posterior spinal arteries. All you have to know is that anteriorly you have one spinal artery, posteriorly you have two, and then they're going to basically supply your spinal cord because it's a tissue structure you want to keep well perfused. And all this stuff over here about the aorta, the subclavian trunk, the subclavian artery, they're all going to make sense once you cover cardiovascular anatomy. So don't fret about it just yet. It'll become more important later on. Okay, so the venous drainage is also very, very similar, except it comes with the inferior vena cava instead of the aorta. And again, you can see it here, and all those words that I'm using, inferior vena cava, they're going to make more sense later on with cardiovascular anatomy. So again, that'll make sense later. Again, the important thing here is the exact same as before. Just remember the anterior and posterior spinal veins, and you're good to go. There's one anteriorly, two posteriorly. But also important here is that these veins here are actually unique because elsewhere in your body, the vein, and the reason is you want to make sure that blood flows back to the heart, not down, right? In the lower limbs, for example, you want to make it go up the legs and to your heart. You don't want to make it go down the other way and just pull in your legs. So you've got valves there to ensure that. But over here, the valves are actually absent. And what that means is, we sort of explained that in the notes as well in detail, explaining the actual mechanism. But say, for example, there's a cancer in the prostate, right? The prostate is connected via to the vertebral column. But because this venous system here doesn't have valves and it's in the midline, it's got equal pressure from both sides coming into it. So that means the blood from left and right is actually got equal pressure, which means it's sort of hard to decide whether it's going to go more to the left or more to the right. It's not like net direction really, right? So blood is sort of slowed down there. And what that means is there's a higher chance that the metastasis, so circulating cancer cells, can actually slow down there and deposit and then cause cancer in the back or the vertebral bones, right? So the dangerous part is that it can actually travel up the spinal cord because, again, these veins are all interconnected as they go up and eventually potentially even cause cancer in the brain, which is why it's important to understand the clinical anatomy, to understand the clinical aspect of it as well. All right. And now clinical applications. So the very, very last bit for back anatomy, you have your spinal, so your spinal anatomy, spinal cord anatomy is important to actually understand because it's going to be used to locate sites for injection or even removing substances from the spine. So the first idea is the spinal tap procedure, which is also called the lumbar puncture, which I like that name better because it sort of tells you where it's happening. Lumbar puncture, it's going to happen in the lumbar region, so your lower back, right? And what's happening here is you're actually drawing out or putting an injection in and then sort of withdrawing CSF, cerebrospinal fluid, for analysis for some reason, right? And again, the important idea here was that you want to do it in the subarachnoid space because that's where the CSF is located, between below the arachnoid layer and above the pia mater. So below the arachnoid mater and above the pia mater. So that's where you have to draw it from. But the part which makes it difficult is that if you look on the diagram up here, that space is actually quite small between the pia mater and the arachnoid mater throughout most of the spinal column. And what that means is that it's going to be very difficult and even dangerous to do it up higher because you actually have a chance of piercing the spinal cord. So instead, you have to actually let the spinal cord go down and wait, because at that bottom bit where it's got the cornus medullaris, it actually becomes thinner and the subarachnoid space actually expands and becomes a thing called the lumbar cistern. So it becomes much bigger. And so if you inject into here now, there's a much lower chance you're going to pierce the massive spinal cord. And therefore, it's much safer to do this procedure. And in terms of anatomy-wise, like what location we choose, I think it sort of differs between clinicians sometimes. But the main one that's taught, across the internet as well and across the textbooks even, is L3 to L4 is approximately where you're going to insert the needle. Because again, remember, the cornus medullaris is going to happen around L1, L2, because L1, the spinal cord is done. And then below that, it's pretty safe to do it because that's going to have that big lumbar cistern where you can grab the cerebrospinal fluid from. So I hope that sort of makes sense. And the next bit of anatomy, or it's bit of clinical anatomy, is the epidural. So that's basically, you might have heard that before, given it's sort of an injection anesthetic that's given, for example, during pregnancy to relieve pain. It's a local anesthetic injected into the epidural space. So again, epidural means above the dura mater, the outermost thick layer that surrounds the whole spinal cord, the outermost meningeal layer. And the epidural space is going to be injected with this anesthesia. And the outcome is that it'll actually affect the nearby nerve roots and therefore produce, so it sort of like blocks the nerves and therefore prevents pain sensation traveling up to your brain. And so you don't feel pain there. So you can inject it at any level, depending on the desired level of analgesia. So for example, if you want to have analgesia for your arms, maybe you do it up in the cervical region. If you want analgesia down in your back, you do it in the lumbar region. So it depends where you want to do it, right? So that's the important distinction here. The lumbar puncture, you can only do it L3, L4 because the subarachnoid space is only big there. It's safe to do that. But the epidural you can do anywhere, depending on your clinical application and what you're trying to actually, the desired level of analgesia, right? So keep that in mind in terms of the distinction there. And the next up, we have some more clinical applications, right? So here's again that mnemonic, the lordosis mnemonic, right? The way that I remember it is lordosis reminds me of a fat lord, and therefore I think anterior curvature, and that's how I remember that word there. Now, again, sometimes naming in medicine isn't that great. So lordosis refers to anterior curvature, but we also use that same word to describe excessive curvature, right? So lordosis refers to the normal curvature of the spine anteriorly, but instead of calling it excessive lordosis or pathological lordosis, we just still call it lordosis, even when it's pathological, when it's too much, which is a bit confusing, but just keep that in mind. When you see those words being used, they can use to describe both normal lordosis, so physiological lordosis, and pathological and dangerous lordosis, where it's just doing it too much, right? So you can see here that you can actually have excessive lordosis in your lumbar spine. And so that's going to really like come outwards. And we call that a sway back because your back is sort of held back, I guess, is the word to use there. And you can see the diagram on the left there, which shows that sway back. And you can see that person sort of leaned back almost because of the way the spine is oriented. And you also have kyphosis, which can be, if it's excessive in the thoracic spine, it's called hunchback, because again, it makes that region, the upper back, protrude outwards and look like a hunchback. Then you have the last one, which is scoliosis there, which is not to do with anterior or posterior excessive curvature, it's to do with lateral curvatures. So that's where your spine is curved more laterally to one side. And therefore, that's something you can also identify in imaging specimens, a lot so in X-rays as well. Next up, you have your clinical application of nerve root compression, probably the most high yield bit of back anatomy, I'd say. And the first thing you want to talk about is disc herniation. So that's where we talked about the intervertebral disc and the structure. Remember, there was the inside bit called the zonula, or the nucleus pulposus, and the outer bit called the annulus fibrosus, right? Now, what's happening in this situation is that the nucleus pulposus is actually protruding out, so herniating, which is another word for protruding out, of the annulus fibrosus. And if it does that ventrally, you can actually squeeze on the nerve there. And so what that means is that entire nerve and everything it's innervating, it's going to be impaired or damaged or affected in some way, which depends on the level of compression sometimes. So if you have that, you're going to have unilateral effects, right? Because only that side is affected, not both sides, just that specific left side over here in this case, right? What else? So that's, oh, actually the right side here because we're looking top down, but that's what's going to be affected unilaterally. And an example of its effects is cauda equina syndrome, right? Which is where compression of your lumbar nerve root, which again can be caused by disc herniation, for example, that leads to motor and sensory innervation loss to the legs, bladder, and the anus. I've spelled bladder wrong there. I'll fix that up again as well. But it leads a loss of innervation to those structures, both motor and sensory, which means you can't feel and move them as well. So you're going to have sensory loss in your perineal area, which is the saddle area between the genitals and the anus. And you also have urinary and fecal incontinence or retention, depending on the type of damage or nature of damage that occurs. Basically, you can't really control your bowel movements that well. And you're also going to have lower limb paralysis potentially. Again, this all depends on the level of damage. So you can also have lower limb paralysis, also sciatica as well, where you have pain going down the leg because of damage to the nerves roots, right? And the most important idea I want to really emphasize here is that when you affect a single nerve, like with herniation over here, right, you're going to affect one side. So it's going to be unilateral effect because that nerve is innervating one side. The other side still has the nerve intact. It's going to work fine. Unless you have structures that require nerves from both sides, which we'll probably cover later on in abdomen. But for now, just remember that one side, the nerve root being affected, one side effect, so unilateral effect. Whereas if you have a cord level injury, so you're basically damaging the middle bit, that cord, right? Then that's going to affect both sides because you're damaging the centerpiece of the spinal cord, right? And as a result, you're going to have bilateral effects. Not just that, but if you damage the spinal cord, then what's going to allow the structures below to actually still work? So you're going to have bilateral effects and also down the spinal cord. So if you had that injury occurring maybe in the lumbar region, then lumbar and below would be affected. But if you have it in the cervical region, then cervical and below would be affected, which is very, very dangerous because you might actually lose innervation to vital structures like your heart, your guts, your other organs, right? So the level of damage will, will determine the level of the effect that's happening as well. All right, so the last bit I think here is all these words containing spondylo. So they give you a bunch of words: spondylosis, spondylitis, spondylolisthesis, which is a mouthful. So a lot of them just are like these words that seem very random, but they actually have very important meanings particularly the last two there are important to remember. But the first one over here, not that high yield, just basically a general word for pain from a degenerative condition of the spine, usually like osteoarthritis and things like that. It's an umbrella term, really. So you can use it to describe general degenerative conditions of the spine. Ankylosing spondylitis is a rare type of inflammatory autoimmune arthritis. You might remember learning about inflammatory arthritis or autoimmune arthritis like rheumatoid arthritis. Well, this is a different type of arthritis called ankylosing spondylitis, where you also have a similar thing where your joints are being attacked and there's inflammation occurring there. And it most commonly occurs with the sacroiliac joints, potentially because that's where the lower limbs connect to the spine and therefore they receive a lot of trauma. I'm not too sure why, but they can occur. They most commonly occur there. The spondylolysis refers to, again, lysis or breakage, which is a fracture, a stress fracture to the pars interarticularis. Now, we talked about the structure of the vertebrae, but we didn't talk about the pars interarticularis. But it's actually pretty easy to visualize, really. So over here, you can see the vertebral body, the vertebral arch, but there's also this bit which we call the pars interarticularis, which is the bit between the body, or the arch actually, between the arch and the inferior articular process. So that's kind of, I guess, not labeled as well here, but it's supposed to be the bit between the vertebral arch and the inferior articular process. Yep, so that's sort of what the pars interarticularis is, that bit there. And when that fractures, right, we call that spondylolysis, so breakage or lysis of that part. And if that occurs, then that vertebrae is free to actually anteriorly displace. It's normally held there by the bone and the ligaments, but again, with age, they can weaken. And so you have this condition where there's anterior displacement of your spine called spondylolisthesis. And that's where, yep, your top bit over here, so the lumbar spine anterior displaces. And you can see the effect of that is that it actually pinches on the nerve that's running inside the vertebral column, which is, again, going to have consequences clinically, which we'll be discovering and talking about in your LOs as well. One thing I want to cover here as well quickly is also with the previous topic over here, if I go back, nerve root compression, they'll probably ask you a bit about the effects of aging on your spinal, on your intervertebral disc, sorry. So with that, there's a couple of things you want to keep in mind. And again, it'll be sort of discovered, it'll be talked about more so in your, I'd say probably more so in specimens. But as you age, what's happening is that the nucleus pulposus, that bit at the gel bit in the inside, it actually dehydrates and shrinks. potential reason why is that this protein inside it called the proteoglycans, which are hydrophilic. And as you age, they're actually lost. And so this bit loses the hydrophilic stuff, and therefore less water can be kept inside, and therefore it becomes dehydrated and replaced by fibrous tissue. And so you can imagine that it's losing its shock absorbing capabilities. It's having therefore limited weight bearing capacity. And so as you get older, it's got less and less capacity to bear weight. And so if you hold too much weight, or you undergo some trauma on your spine, so for example, if you're doing heavy lifting where the gravity is pulling down on the spinal cord, or you're jumping and receiving shock from below from your lower limbs impacting the spinal cord, or the pelvis impacting the spinal cord, then that can damage structures, because the annulus fibrosus, that outside bit, will easily tear under that pressure, and the nucleus pulposus will herniate or push or extrude out, and then lead to that disc herniation. And also, generally, as you age, there's a higher risk of osteoarthritis, which means you have a higher risk of breaking the vertebral bones themselves, right? Which means that things like the pars interarticularis fractures, also spondylosis, no, that's the wrong word, spondylitis, is more likely to occur as you age. And therefore, also the spondylolisthesis is also going to be more likely to occur as you age, because that bit can actually anteriorly displace with age. And I won't keep it for too long, but just one small bit as well that I wanted to just talk about is, just a sec. All right, so, no, I think I already covered it. Oh yeah, over here, if I go back to the bit about the veins are not very high yield at this stage. But the only thing you want to remember about the veins is the role it plays in cancer and metastasis. So if you look under this slide in the speaker notes, it's explained here. I've already talked about it before. Just have a look at that and it'll all make sense. If it doesn't, feel free to message me or anyone else in the group, and we'll try and get back to you with an annotated diagram or some other way that will help you sort of better visualize it as well. All right, that's it from me, and I'll pass it on to Janam, and feel free to ask me more questions in the chat. I'll be having a look and trying to answer them as we go.
All righty, thank you. I'm going to share my screen with our next topic, which is on cardiovascular infections. Now, I know microbiology can be a bit intense because it's basically just lecturers throwing at you bucket loads of bacteria names, viruses names, different types of conditions you can get. So I've tried to simplify it here and also sort of stratify it into some of the more high yield things that you should remember for next year and just in general. And then some of the more low yield things, which may be either self-explanatory, and so I will not explain it too much, or they're just like really, really straightforward. So anyways, here's the sort of what I was talking about in terms of stratifying it into high yield versus low yield. I know that I've put most of the conditions into high yield because they are very, very important to understand, especially infective endocarditis. This is something you'll come across time and time again. You will come across it in clinical skills when you're doing your physical examination findings. The other ones are also kind of self-explanatory. So I'm not sure if you guys have covered, actually you probably wouldn't have covered the anatomy of the heart yet. So this might require a little bit more explanation, but these are just the infections of different layers of the heart. So you got endocarditis, myocarditis, pericarditis, and then going out to mediastinitis. You've also got acute rheumatic fever, which is autoimmune condition, which we'll cover soon. The low yield cardiovascular infections are not super important, but I'm still going over them just for completion's sake. And if you have any questions about them, either look at the lecture slides for more detail or send me a message and I'll help you out if there's any confusions. And then pyrexia of unknown origin is just a bit of a fun one to think about. Okay, so infective endocarditis. I'm going to go into this in a lot more detail than the other ones. First of all, you've got different layers of the heart. And if you try and work your way from sort of inside to outside, starting with the inside, you've got endocardium. So endo meaning inside. So this is going to be an infection of the endocardial surface. And generally, obviously, you've got a lot of things happening inside the heart. You've got like the membranous layers that are covering like the atriums and the ventricles. But you are typically going to find endocardial infections to be on the heart valves. And the reason why you get that is mostly because the blood flow through the heart is going to be quite smooth up until you hit the valves. At the valves, you're going to have a lot of turbulent flow. And that's just very ideal for bacteria, because where you have turbulent flow, you're not getting those bacteria being flushed out, or bacteria, viruses, whatever it is. It's not getting flushed out at those points. It's going to get stuck because it's all going in a circular path. That's why valves are most commonly affected. But you can see there's a variety of different places that can be affected on this diagram. So the pathogenesis is relatively straightforward. First of all, how do those pathogens get in? They either gain access to your bloodstream. So that's like, for example, if you insert a catheter, if you have IV fluids being inserted in or something, you're introducing foreign bacteria into your bloodstream. Or as we will see in a second, you can have them being introduced via the oral cavity. So that's another really important mechanism by which they can enter. The next thing they do is obviously they're going through the circulation, going everywhere. Eventually they'll end up in the heart via systemic venous return, and they will end up in one of the valves. And they form what we call vegetation. So they grow, so they stick to the valves, and then they start to grow and grow and grow. Generally, people who have congenital septal defects, because again, you have septal defects, you have more turbulent flow, they're going to be more prone to infective endocarditis. The real danger with this, apart from the growth happening on the valve and deteriorating the function of that valve, is going to be because those valves are constantly opening, closing, opening, closing. You might get those bacteria or those vegetations getting flicked off. And say, for example, they're getting flicked off up to your aorta, and they're going up to your brain. That's going to cause those bacteria to form vegetations around your brain, or at least in the arteries and veins around your brain. And that's going to mean you're going to have reduced blood flow to various organs around your body. So that's definitely not an ideal outcome. So some of the complications include things like septic shock. Not sure if you probably covered this. So septic shock, the embolism, or basically the clump of bacteria moving around, getting clogged somewhere and stopping blood flow to a specific region, or the formation of an abscess. So you can get pus and things like that because of inflammation. So really a very important and quite unfortunate condition that many patients can come in with. Now, it's really important to understand that not all presentations of infective endocarditis will be the same, and there are general risk factors associated with each of the different types of bacteria or viruses that can affect patients with infective endocarditis. Now, there are many, many, many risk factors, but the most important is IV drug use, because as I mentioned, you're introducing a foreign pathogen into your bloodstream and basically giving it direct access to your heart. And I say IV drug use because that's where things are going to be a lot less sterile, but it can also be in a hospital environment. So when you have cannulations and things, if they haven't been cleaned properly, then that can be another mode of transmission. Now, it's important, it's pretty high yield because sometimes you can get this in an exam. When you have IV drug use, and I know this is really unfortunate because you haven't covered circulatory systems and heart anatomy yet, but when you do cover that, come back to this, because what you're having is with IV drug use, you're basically inserting drugs into your systemic venous circulation, right? And all that systemic venous blood is going to enter through your inferior vena cava into your right atrium. That's kind of where most of that blood is going to be going into. Now, this is a problem because that gives them direct access to the tricuspid valve, which is basically separating the right atrium and the right ventricle. So they can cling onto the tricuspid valve, and that's basically the place where vegetations are going to form, mostly if you have IV drug users. For non-IV drug users, it's generally not the tricuspid valve that's affected. It's mainly the mitral and aortic valves. So we're thinking more about the left side of the heart in those situations. Okay. There are some other predisposing factors that are also important to remember. So they have dental surgery, poor hygiene. You may have injections, cannulations. Anytime you're inserting external objects in, so pacemakers, prosthetic valves, anyone with congenital heart disease or other infections that are spreading into the circulation. Now, the reason why this is so important, why this is stressed so much to medical students, is because it can be really easily cured if we know that someone has infective endocarditis, if we can screen it. The only thing is, if it's not treated early, there's a very, very high mortality rate. So it's like 40% within 1 year will pass away because of infective endocarditis. So let's go on and discuss some of the clinical features. Before we do that, just a quick word on the pathogens. This is probably the most high yield slide out of them all, just because they can ask you more questions about this in an exam. So you've got two main types of presentations. You've got your acute ones, which happen over days, and you've got chronic infections, which can happen over weeks. Now, it makes sense to think that if it's acute, it's going to be a very, very virulent organism. So in other words, causing more damage. So it's usually associated with Staph aureus infections. So potentially, other IV drug users from the skin, etc. With the chronic infections, it's going to be more low virulence. So they're like fastidious. So like they're sticking around in your body, but they're causing damage really, really slowly. And this is probably a little bit more dangerous just because you don't know if someone has infected endocarditis until a lot later when they start to show symptoms, by which time it might be too late. So these are, for example, Enterococcus or Viridian strep species. Some extra things. So with the acute infections, the patient is likely to have some structural heart disease that predisposes them. So for example, they have a congenital heart disorder. And with chronic infections, there may be other abnormal structures that are present. So they may potentially have a valve that has been, an artificial valve that has been inserted in, which makes them more predisposed to these sorts of chronic infections. The bottom bit is the most important. So if you're thinking about what sort of bacteria you can suspect based on a patient's history, think about these ones. So you've got dental work. In that case, you're thinking about what are some of the bacteria that are present in the oral cavity and that could cause opportunistic infections. So one is Viridian streptococci. With mitral valve replacement, you're thinking mostly about coagulase negative staphylococcus, and that's just potentially because that mitral valve hasn't been, or that replacement hasn't been cleaned properly or sterilized. With IV drug users, think about skin bacteria that are getting into your bloodstream because of, again, not being sterilized, so Staph aureus. And then colonoscopy, if you think about a perforation to your colon when you're trying to insert, like for example, a little camera in, you're thinking about what sort of gut bacteria can enter into the bloodstream. And in this case, it's going to be Enterococcus for the most part. Okay, again, this will be covered in your clinical skills. It's really important to get really good at looking for hand signs when you're looking for infective endocarditis, because these will give you an early indication that someone has the condition. So splinter hemorrhages, Janeway lesions, Osler nodes. I'm not going to bore you with this right now. It'll come next week or the week after. And the reason why we obviously care about these is because of all the end organ problems that we're trying to avoid. So we're trying to avoid it getting into the ocular circulation. We're trying to avoid it getting into the cranial circulation, to the spleen and so on. So what do we do about this? Well, when we're trying to diagnose infective endocarditis, there are a couple of things you should be aware of, as well as a couple of catches to the process of diagnosis. So the gold standard is always going to be a blood culture. You always have to make sure that you get 3 sets of blood cultures, and you are trying to get the first and last one to be 1 hour apart. And the reason for all these different nuances is, first of all, 3 sets increases your accuracy. So you're just making sure, and obviously because you definitely don't want to miss this. So if one blood culture returns negative, you don't just want to say, oh, this patient doesn't have infective endocarditis, because they could. And we've seen the high mortality rate. So you really want to screen it properly. So it's really important to get these 3 within 1 hour of the first and the last. You can also consider things like white cell count, CRP to look for inflammation, the valve histology to check for any of those vegetations, and so on. And other really good investigations to consider would be ECG to look for any rate or rhythm changes, chest x-rays, echocardiograms. So you've got transthoracic echocardiograms or transesophageal echocardiograms. All of these, you can see at the bottom, you can see how, I believe this is a transesophageal. Not really good at reading these yet, but these, like, it'll show you a kind of disorder in one of the valves. You can see there's a tough sort of vegetation forming there. There are also a couple of criteria that your lecturer goes over, and I think probably the most important one to just be familiar with, or at least know it exists, is the Duke criteria. So that'll just tell you what factors need to be kind of checklisted to say that a patient definitely has infective endocarditis. And some other ones will indicate whether that patient needs surgery right now, or it can wait until you've gotten something confirmed with your blood tests. But these are not super high yield, so don't worry about them too much. Here is what is super high yield. So when you get a negative test on your blood culture, you don't want to be necessarily ruling out infective endocarditis, because there are a multitude of reasons why you can get a negative test, even when the patient has IE. So for example, and this is probably something you want to avoid as a physician, is actually administering the patient antibiotics before the sample is taken. That kind of defeats the purpose of getting the sample. This might not be because you gave the patient antibiotics. It might be because the patient was feeling sick and they took them. So you want to ask Did you take antibiotics before? If they did, then you want to be wary that the blood sample might return negative because some of the bacteria may have been destroyed already. They could, as well as the first reason, they could be in a subacute stage or at an end of chronic stage of IE, which, although it can still be lethal, it's harder to detect because those bacteria or pathogens are already at a lower concentration. You may have certain slow growing or fastidious organisms, and there's a group called the HACCP group. There's a full acronym you can look at, but the HACCP group is clinically important because they are going to be things that grow a lot slower than like your run-of-the-mill Staph aureus infections. You can also have organisms that are just not going to come up in blood tests. So fungal organisms, which you might not be growing for, or obligate intracellular parasites, which are obviously inside cells. So they may not be as easily drawn out by these blood cultures. So basically be really careful that you don't just rule out IE because something came back as negative. All right, now how do we treat it? Well, you can start off with empirical therapy. So why do we even consider empirical therapy in the first place? Well, if your patient has infective endocarditis and you're trying to go for 3 blood cultures, those blood cultures are not going to take a couple of minutes. They're probably going to take hours to days. And in the meantime, your patient's prognosis could be getting worse and worse and worse because of the vegetation's growing, the chance of them flicking off into different organs and causing an embolus. So in the meantime, you can give your patient antibiotics to ensure that they don't get any of those really end organ complications. Now, I did a lot of digging, and your lecturer goes into a couple of different medications, but I just did a little bit more extra research, and there are so many nuances to this. There are a lot of criteria you can use. The medication will depend on your clinical expertise most of the time, but a lot of the sources will confirm that penicillin is generally the one that's most prescribed, and you can add on drugs like ceftriaxone or ceftriaxone, because these are really good for both native or prosthetic valve, IE conditions. You can also give prophylactic antibiotics in case you know that your patient has a certain cardiac condition and you know that they're going to undergo a procedure that increases their risk of developing IE. So if they have a dental work happening or something like that. Penicillin is really a superpower of the medical industry. So if you think about a condition and you're not sure, well, probably not. Don't go for that advice. For the most part, though, like 80% of the time, a lot of conditions can be cured with like antibiotics such as penicillin because they're just so broad spectrum. Okay, now extra sort of layers of the heart that can be affected. So we're working from in to out. The next layer out, as you can see this diagram, and again, I'm acutely aware you haven't done heart anatomy, so just keep this in the back of your mind when you're discussing these conditions. Myocardium can be affected, so that's the muscle layer. And the muscle layer is super critical because it's going to be the part where the nerves are going to be innervating, right? All the internal conduction system of the heart is going to be innervating the muscles, which allows it to beat. So if you've got an infection in the myocardium, apart from making the muscle cells themselves, damaged or weak, it can affect those nerves and therefore lead to abnormal heart rhythms, or otherwise known as arrhythmia. So this is a very common reason for sudden death in young people. Generally, even in postmortem, the cause is not found, but it seems that there's going to be mostly viral etiology. And you can go into some of the more, I guess, specific pathogens in your lecture. With pericarditis, so I think we discussed this. So we talked about the pericardium a little bit. It's just, again, the serous, like the layer of mesothelium, 2 layers of mesothelium that are covering the serous fluid. So if you have an infection there, again, we're not really sure what causes it, but it can be viruses, bacteria. You will go over this in clinical skills when you discuss things like pericardial rubs and stuff like that. When you've got your patient not breathing in, so you're sure it's not lung involvement, and you put a stethoscope over the heart and you notice a pericardial rub, then that is a pretty high probability that they have pericarditis. It's not always infectious though, so keep that in mind. It can be other causes. And then finally, mediastinitis. So this is outside of the heart. It's the space between the 2 lungs. You've got different parts of the mediastinum. But if you have something like an esophageal perfusion, perforation, so you've got damage to the esophagus, and that can be iatrogenic, so during surgery, or it can just be spontaneous because of having a weak esophageal wall, that can cause, all the acid and things to kind of spurt out and damage the layer or damage the space in the mediastinum. And obviously you've got a lot of important structures in that region. Head and neck infections can spread there, surgeries can cause damage, and so on. So these are all very common, or at least they're all very similar. It's just that they're affecting different parts of the heart or layers outside of the heart. And then finally, the last high yield one to remember is acute rheumatic fever. So this is an autoimmune response. And how it starts is you've got just a run-of-the-mill infection with strep throat, or more specifically, it's caused by beta hemolytic group A strep, so GABS or GABHS. And that will normally just cause you to have a sore throat. However, unfortunately, in some patients who are predisposed genetically or by the environment, what can happen is that your immune system, it does produce those antibodies, which are effective against the antigens on the GABHS pathogen. But these antibodies also are very similar or target the tissues in our heart. So unfortunately, the antigens on the GABHS pathogen are very similar to the antigens on heart tissues, for example, the valves. So those antibodies can actually cross-react and cause damage to itself or the host tissues. And if you have repeated or chronic infections, you keep getting like strep throat time and time again, you can develop rheumatic heart disease, which can be quite fatal. So again, this is something that should be screened early. Okay, some of the more low yield ones, please don't go to sleep because you might get a question on one of these, I'm not sure, but they're just really important to keep in the back of your mind. So we already went over one of these. Anytime you insert anything into a patient, you have a risk of introducing stuff from the outside environment into their body. And it's never more true than for cardiac devices because you are literally giving them access to your bloodstream. The bacteria, pathogens, whatever it is, they can go anywhere they want from there. So, things like pacemakers, catheters, which were going up from the femoral artery all the way up to the heart, again, direct access to the heart. So all of these devices can risk introducing pathogens. 2 or 3 more extra ones. So suppurative thrombophlebitis, it's a mouthful, but suppurative just meaning pus. So what we're getting is we're getting inflammation of the walls of the vein because a microorganism is present. And what's happening is microorganism sticks to the wall of the vein. Your body tries to attack it. So inflammation and things like that, that's going to cause the vein wall to become weaker. It's already quite thin. So this can be problematic. And this can cause things like thrombosis. So microorganisms clump together and spread everywhere, or bacteremia, which is already infection in the arteries or the veins. So who's responsible? Staph aureus, Klebsiella, Candida, Enterobacter, and so on. Mycotic aneurysm is, so aneurysm we know is just abnormal dilation of your arteries. Mycotic just means it's to do with a bacterial or basically a infectious cause. So this can be a complication of infective endocarditis. And here's just a list of ways that you can get a mycotic aneurysm that you can read in your own time. Who's responsible? Again, Staph aureus is the big killer. You've got strep, salmonella species, and so on. And then finally, this is just a really interesting one to think about. If you're ever stuck in your history taking, your patient has a fever and you're not sure, please don't just say it's PUO, because I know PUO is basically a little bit of an excuse sometimes if your patient has an acute fever and you just can't figure out what their diagnosis is. Some people will just say, oh, I'm not sure, it's PUO. But PUO is not technically a diagnosis. It's kind of when you've exhausted all other diagnoses and you've kind of finished all your investigations, because you can't say what the patient has, you say, okay, I've done everything I can, they have PUO. So the criteria is quite stringent. So you need to have a fever that's greater than 38.3, and it has to be over at least 3 occasions just to make sure that it's legitimate. The illness has to be greater than 3 weeks, and you shouldn't have been able to make a diagnosis after 1 week, given that you've done all the reasonable investigations that anyone in your position would have. So the causes can be a lot. So infectious, obviously, what we're discussing today, but you can have inflammation, you can have cancers, neoplastic growths. And I like how it says other, because that's basically what PUO is. It's just an unknown cause. You don't really know what's causing the acute fever in this patient. And that's it. Okay, if anyone has any questions, please let me know. I'm aware of time. So I'll give it on for like developmental psychopathology, and I'll answer any of your questions in the chat if you have any. Thank you.
Easy. So developmental psychopathology is basically the study of how people with mental disorders develop over time. And also how those manifest at different ages and life stages. So that's the general overview, and we'll be looking at a few certain disorders and how they present over time and that sort of thing. So I'm going to try and focus on the most high yield stuff because these don't take up a huge portion of your exam, but the few things that do come up, it can be quite difficult if you aren't across them. So we'll try our best to give you an overview. So the first things I want to get across to you are that mental illnesses are surprisingly quite complex. And so we usually have multiple factors which actually lead to a mental disorder. It's very hard to pinpoint one thing, although in some cases in some cases you can pinpoint one major cause, but in almost all cases you'll have a complex multifactorial etiology. And it's also hard to tell how factors will work because of two concepts we have here. So the first thing is that you can have the same risk factor, but different outcomes. So two people might be exposed to the same traumatic event, and one of them might develop, say, depression, the other person might develop borderline personality disorder or something, just an example. So you can't predict the outcome of a person based on the risk factors. There's just too much complexity in the interaction. On the flip side, you can have the same outcome from different factors. So people can be exposed to different traumas or events and result with the same disorder. So we need to be aware of both of those things because they both factor into how people develop these. And in terms of definition, it's quite difficult to define these compared to many medical conditions or physiological conditions, because those we can often point to very or relatively clear biological markers and say, okay, well, this is that, this is above this number, this is within this number, we can classify things based on that. Whereas with mental disorders, it can be a bit more sort of fuzzy. There's a lot more subjective stuff, there's a lot more stuff that's very much on a spectrum, where one side is sort of clearly impaired, one side is clearly normal, but it can be very hard to draw that line, whereas it's usually a little bit easier with somatic illnesses. Okay, so we have a few theories of how mental disorders work. So we're going to just go through these briefly and then get to the actual disorders. So Sigmund Freud, had a view of mental illness which basically said there are three parts to your mind. Okay, you've got your id, which is sort of your lizard brain. It wants pleasure, it wants food, it wants shelter, it wants all of that sort of stuff. Your superego, which is sort of, you know, your higher mind per se. So your values, your morals, all of that sort of stuff. And then your ego is sort of the middle you, or like the conscious you. And so the conscious you, or your brain, is constantly trying to mediate between I want hedonic blah 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 and I want to fulfill my values and morals. And so he said basically anxiety and other issues are caused by a conflict between what you want hedonically in terms of pleasure seeking and what you want in terms of your values and moral. And he suggested that things arise based on that. So we kind of don't put too much stock in that theory these days. It's still important as a marker for like different ideas of how mental illness works, but we don't necessarily lean on it too much. We've also got the classical behavioral approach. So this is, if you remember classical conditioning, it's basically like you have a neutral stimuli and a harmful stimuli. And if you associate them enough, then the neutral stimuli becomes a perceived harmful stimuli, and then it starts triggering adverse responses even by itself, where there's no real danger. So that's the general idea there. We've got social cognitive theory. So this one's sort of an advancement or an evolution of the classical conditioning, where we sort of branch out more and we say, well, things aren't only conditioned, we also learn, and we also have the ability to incorporate and integrate other people's views into our worldview. And that can be quite important for these. So not only do we bring in the concept of self-efficacy, so your ability to master a skill, to achieve, to do things, can be very important, especially for things like anxiety and depression. They can depend a lot on whether you perceive you have the ability to change things. And also there's the idea of things like self-image and how that can be learned as well. So you can observe people's opinions of you and people's interactions towards you, and then internalize those. And then finally, we have the sort of biological approach, which is not necessarily, none of these are necessarily in conflict with each other. They can all be seen as complementary or different outlooks on the same thing. Biological is sort of often its own corner because it's not psychosocial like the other ones. It's in its own realm. And this one is basically, when we look at a lot of disorders, we see that they correlate with X problem with neurotransmitters. So there's probably some causation there. And that's a good thing in some ways, because it means that it's easier to treat those things, because it can be a lot harder and a lot more messy to treat things with therapy. At the same time, we don't want to reduce everything to biological causes, because they don't have full explanatory power. We can't explain everything just using biological evidence. Okay. So the first one we'll look at is ADHD. So biologically, there's an imbalance of dopamine and noradrenaline, and then psychosocially, things that can cause when I say parenting there, so it can be deficits in parenting, basically not socializing the child correctly, and also having social interactions which are perhaps negative or abnormal in childhood. So again, these are not in competition. They can be sort of both feed into one another. And so they should be viewed in concert. So in terms of diagnosis, you guys probably have a pretty good overall idea already. So we have impairment in multiple environments. So if it's one environment, we probably look into the environment before we look into the person. If it happens in multiple environments, we might consider there to be some sort of impairment in the person themselves. And then inattention, hyperactivity, and impulsivity, pretty classic stuff that you guys will probably have seen in popular culture. So in terms of treatment, so we'll use stimulant medications. So you might have heard of Ritalin. That's the trade name. The full name is methylphenidate. They don't actually address the causes, is the problem with this one. So they typically treat the symptoms more. But in terms of treating the causes, we usually have to go to psychosocial interventions. So things like behavioral therapy and training parents to interact with their children. So depression, so we do need to make a distinction between depression, the emotion, and depression, the disorder. So people sort of use it in popular culture and discourse to just mean sort of intense sadness, which is not really what we talk about here. So physiologically, we think it's linked to serotonin and cortisol in particular, and also noradrenaline. And psychosocially, we can have trauma leading to depression. We can have negative self-image and self-efficacy, like I mentioned before, and negative life events. They can all contribute to depression. So there's two sort of key symptoms for depression, which you should probably know, is one sort of depressed mood, so having that lowered emotional state, and also critically having a loss of interest or enjoyment in normal activities. So things that used to make you happy don't make you happy anymore. Things that used to be interested in, you don't care about anymore. Those are sort of the hallmark ones. We have other symptoms as well, which are listed there, but those two are sort of essential to making a depression diagnosis. In terms of management, so we have a lot of antidepressants out there because it's pretty widespread. And so probably one of the well-known ones, Prozac, fluoxetine, and that's part of the wider sort of drug class of SSRIs. And they selective serotonin reuptake inhibitors. So that is sort of dealing with the serotonin dysregulation. Psychosocially, we can do cognitive behavioral therapy, and that sort of ties into that theory of learning and how we can then ameliorate it. Schizophrenia. So we have too much dopamine, basically. There's also a lack of white matter. So that's talking about actual brain anatomy and structure. It can also be sort of fueled and contributed to by the family environment. So sorry, I think I haven't made it super clear, but these disorders that we're looking at, these are all looking at childhood manifestations, which can then, sort of continue into adulthood. But that's why we talk a lot about parents and the family environment. We then have delusions and hallucinations. So the sort of defining characteristic with these is that something that's real to the person, but not to anyone else. So you need, you can't say that someone has delusions just because they're wrong about something. It needs to be something which is real to that person. They believe something to be real when it is not. We think there are other symptoms as well, but they're not as sort of specific. although neglection of self-care is actually an important one, and that's one that you'll see show up as sort of a social history thing that can help lead to a diagnosis. So in terms of medication, we again have sort of the duopoly of antipsychotics on one hand, so trying to treat the chemical imbalances, and then treating it with psychosocial interventions as well. Right, and the last sort of major group is conduct disorders. So this one's a lot more fuzzy. We don't really have a good biological cause for it. This is sort of a very difficult one to disentangle from things like low socioeconomic status. But the sort of overall diagnosis, the defining characteristic is persistent antisocial behavior. So it's normal for children to have some level of acting out. That's not what we're talking about here. This is sort of specifically antisocial behavior, and it's happening over a long period of time and to an extreme degree. So again, because we don't really have a biological cause, we don't really have a pharmacological management for this one. And so it focuses more on psychosocial intervention. Okay, we also have a whole bunch of personality disorders. Don't be overwhelmed by all the names. This is just to sort of give you an overview. But basically, I won't go through these in too much detail now because pretty much all the information you need for an overview is on the slide. But we basically have three big sort of continuums or categories that we look at, which are schizophrenic, psychopathic, and neurotic. And so each of them has sort of hallmarks. So schizophrenia is sort of social disengagement, sort of suspicion, paranoia, all of that sort of stuff. Psychopathic has to do with sort of emotion. So a lot of them, you have a lack of empathy. You can't empathize, can't relate to other people. In histrionic and borderline, those are both sort of linked to attention seeking, among other things. So borderline is quite a complex one. That's also one of the most common diseases. So I think the prevalence is like 2% of the population or something. So that's quite a significant size if you think about it. And so that one has a very wide variety of presentations. So it's sort of just deeply unstable in a lot of different ways. And so you can read more into that if you'd like. And then finally, the neurotic one. So the neurotic one is sort of if I had to categorize it or define it, it's sort of caring about things. So dependent PD, we have sort of over-attachment, you're very clingy, you sort of fixate on a person. Avoidant is you care a lot about negative feedback, and you have sort of very deeply affected by having negative feedback. And obsessive compulsive is you need things to be ordered and controlled. And then anxiety disorders, this is now moving into adulthood. So a lot of the other things that we saw in personality disorders, they show up more in adulthood or late adolescence. Things like ADHD we usually actually diagnose during childhood, whereas these ones get harder and harder to spot. But in terms of adulthood, so this is sort of full spectrum. So the causes, we can have various neurotransmitters. This is sort of quite a wide range of things. And so we have a lot of different causes, and we think that there may be a genetic element. But yeah, so the sort of presentation of anxiety changes over time. The hallmark here is it's an excessive response to, it's disproportionate. So that's the sort of defining factor of anxiety disorders, that they are not proportionate to the stimulus. So it's okay to be nervous, it's okay to be anxious as a mood. Anxiety as a disorder is what happens when your response is more than is reasonable, basically, in that situation. So it sort of changes over time. So in childhood, you might have a kid who's very clingy to their parents and doesn't like being abandoned there. You might then have social issues in your sort of formative years, and then you can have sort of panic situations where people are put in a stressful situation and don't handle it well during adulthood. So in terms of management, we again have quite a wide range of treatments available for it. So benzos and SSRIs again, and psychosocially, we can look at cognitive behavioral therapy. And again, so remember, pharmacological and psychosocial treatments are not in opposition. So we don't pick one or the other. We usually do both, and we try to synergize them as much as we can. Okay, and final little bit here this is sort of the 3-step theory of suicide from Klonsky and May, which is the one that Monash teaches, or at least presents as an important one. So in terms of the actual path, the idea is it's basically a number of decisions. So the first one is sort of the stimulus. So, there's pain and hopelessness, which you can see how that can manifest in depressive disorders. So that leads to suicidal ideation. And we then have sort of the escape step, of the reason that social connection is so important, the reason that we look into things like cognitive behavioral therapy and social solutions to depression, which is that if people's pain or suffering is greater than their connectedness, then that leads to strong ideation. And then if they have the ability to attempt suicide, so that's not only like the actual straight up physical ability to commit suicide, it's also the sort of social ability or ability to decouple oneself from mental obligations. But if they are in that position, then we get a suicide attempt. So this is sort of, it's not the only way of thinking about suicide, but it is the way, a useful way for us to think about it and think about how we can divert that especially. So yeah, I think that pretty much covers it. So we'll wrap it up there, and hopefully you guys learned something about mental disorders. Remember, they're not super a super big slice about of your exam, but they are important and they do show up. So like this isn't sort of the thing that'll maybe show up or maybe not show up. They are on pretty much every exam. So I would pay attention to them. But yeah, make sure that you, not make sure, stick to the sort of overarching and defining characteristics, because they don't ask you too much on the details. That'd be my approach for doing this. But yeah, thanks you all for coming along, and see you guys next week.